All right. So no disclosures. So we're just going to talk brief overview about the atherectomy devices that are in the market and use and try to use them depending on your convenience and availability. And as we know, not every device fits the situation we want to use it to. So these are a certain few devices that are really available in the US essentially right now. You have the directional atherectomy, the orbital, rotational, laser, excisional, and nowadays we have the lithoplasty, which is the latest technology which we're using. So the background behind using atherectomy is essentially to avoid the induction of potential restenosis. Problem is you have recoil, restenosis, and dissection. So what atherectomy tries to do is do like what we call as plaque modification. It removes the plaque without overstretching the vessel wall. If you have a lot of calcified lesions, a lot of fibrotic lesion where we're not able to achieve good results with PTA, that's where atherectomy adds on as an advantage to being used. The problem with atherectomy devices is there are no real large randomized trials also with as comparing to just drug-coated balloon, drug-coated stent. Long-term patency from the rates of the randomized trials are not available, and each device has its own advantages and disadvantages. So first, let's talk about the laser atherectomy. As the name suggests, it uses laser as its mode of action. You have the laser catheter, which is right here. It's a monorail with a guide wire going through it. So you can actually put your catheter over the wire, pass the lesion, and then you use the laser technology and the heat to actually open the lesion up per se. So the advantage of using laser, it might be useful in small vessels. It's actually known to be superior than balloon angioplasty for ISR. So it's essentially indicated in instant restenosis as well. It comes in different sizes from 0.9 all the way to 2.3 depending on the lumen size. So if you're below the knee, you can use a smaller caliber laser. And if you're above the knee, for the SFA and the POP, you can use bigger size caliber catheter. It also helps in preparation of artery for possible endoprosthesis implantation, and we still need some good studies for it anyways. The disadvantage is very severely calcified lesions. It might not provide enough of atherectomy benefit, and of course fractured stents and also in acute occlusions where other devices might play a superior role than laser itself. The directional atherectomy, as the name suggests, you can see this is the cutting device, but you can direct it manually. So you can do selective cutting rather than the atherectomy doing its own lesions all the way. So this is like the the plaque, which actually comes out from the directional atherectomy devices. There are large series of patients in this directional atherectomy device called the Definite LE trial, which shows the advantage of using these directional atherectomy, which in US is the Silverhawk and the Hawk one nowadays. Like I said, more beneficial in eccentric lesions, vessel size less than 7 millimeters, and for instant restenosis as well. Not to be used in fracture stent areas, very tortuous vessels, because you can have a selection bias, so instead of being able to torque to the lesion, you might just drift away from it, and it might not provide you enough advantage, and also vessels less than 2 millimeters. The next one is a Jetstream Atherectomy device. So the idea is to really do an atherectomy as well as suction out whatever particles you generate, thereby aspirating it and helps so-called preventing distal embolization. So you have both a method where they have an end-hole end-hole atherectomy device. It just runs like a hawk, and then you just aspirate at the same time. More useful in subacute or acute occlusive thrombotic lesions, more say, vessel diameters, sometimes calcified lesions as well. The problem again stays with the fracture stents, and of course if the vessel size is too small, then probably might not do its own job and cause higher risk of perforation. So you always have to be cognizant of the fact when you use this device. The other one, which is more commonly used nowadays, is a rotational atherectomy, which is the CSI manufactured Diamondback. So what it does is it has a diamond crown, and instead of going over the wire, it spins actually around the vessel, thereby giving you this eccentric cut and then increasing the luminal gain. The advantage is that people who do pedal access includes intervention, you can use a smaller size sheath like a 5 French sheath and also use these smaller luminant devices, and it helps you. You don't need a bigger, larger sheath. So it's actually highly useful in calcified lesions, infra-pop and above the popliteal as well. But there is always a risk of perforation and distal embolization. The latest technology finally to talk about is the Shockwave Lithoplasty. It's one of those new things where there's actually lithotripsy emitters. So it's essentially a balloon which has like the emitters in it. So it's a set of 3. So what it does, it generates energy, and the idea, it doesn't cut anything, it doesn't suck out. What it does is it tries to generate energy. So any calcification, more so in the medial and adventitial region, which is hard to treat, it just cracks the calcium. So it increases the compliance of the vessel, so that way your balloon PTA, balloon angioplasty, and then the stenting can have good results. So you get good luminal gain by those the waves itself. So it's significantly used in calcified lesions. We also have adjunctive therapy, but there is no real data to suggest what happens with adjunctive therapy by DCB. There was one trial which showed that, which I'm going to skip, and this is just a brief overview. So depending on what kind of lesion you have, where the lesion is, your proficiency with using the device, there are multiple areas where you can use one device over the other. There is no head-to-head comparison to say one device works better than the other. It's all the advancements, or it's all the selective use. So depending on the mechanism of action, you can use the device per se. And so that's pretty much it. In conclusion, differential debulking concepts are now available for specific lesion morphologies. It reduces the needs of stents. So if you do a good atherectomy and balloon angioplasty, sometimes you just can get away with stent placement, especially people from here at Sinai. We believe in nothing left behind, so we just want to try to avoid stents if you don't have to. May be beneficial in diabetics, and it also might help in local delivery of drug technology, especially in the future endovascular treatment. Thank you.